you guys know me from this morning, and one of the things that I do is I treat patients in the county setting at the Roybal Comprehensive Health Center, but I also treat patients in my own practice through USC, which is a lot like a private practice. And there I get to use basically anything I want. I'm not restricted by formularies. So I use a lot of the newer medications to treat patients. And some of these newer medications, perhaps all of them to some degree, may be coming to you. Now, mind you, we're going to have to stick with looking at cost and making sure that when we use these newer medications, it's in people where we can't get them to target. And there's no reason why we can't use the traditional meds. But they asked me to talk based on some of my experiences about some of the more difficult patients. And I also want you to really think about what you learned this morning from Dr. Fisher. I loved how he talked to us about talking to our patients. I try to listen, but I also know that I talk too much because I'm too anxious to get on to the next issue. So it actually was very good to hear him reinforce how we really should be talking to patients. Now, one of the problems we have in terms of diabetes and medications is that when you look at antihypertensive drugs, the rates at which we've had new ones has been pretty consistent. Every few years we get another antihypertensive agent and we learn how to use it and we add it to the old ones, and it doesn't make our heads spin. But when you look at diabetes drugs, it's a wholly different scenario. So first of all, we've had insulin since the 1920s, and then sulfonylurea agents since probably the late 1940s, early 1950s. We briefly had biguanides in the United States, and they've been used worldwide since 1957. But for a very long time, and in fact, when I was training in endocrinology, all we had was insulin and sulfonylurea agents. And it seems like forever ago that that's all we had. I was actually one of the investigators, along with Mayor Davidson, doing the studies that got metformin on the market in the United States. So way back when, I still have some of those patients that were in that clinical trial that I saw at Cedars 30 years ago. So it's pretty amazing to see the progression over time. And then I also did some of the clinical trials on TZDs. I've really done a lot of the research in the pharmaceutical space trying to get some of these drugs to market. Well, we've been incredibly successful, such in the past 10 years or so, we've had this many new drugs for the treatment of type 2 diabetes. And we basically just keep getting more and more. And it's wonderful. You can combine them all together. At one point, I realized I had a patient on 7 different agents. 7. It nearly killed me to think this. And you know what? No matter what I added and no matter what I did, his A1C remained 7.4%. Of course, because he was taking all these pills, but he just kept thinking that another drug, another thing would make him better. And in fact, it didn't, because he wasn't changing his habits. And so it didn't ever work. Of course, it did work once he had his cabbage and, found religion. But he actually didn't benefit from all those drugs. And I think we can't be under the myth that just giving more medications fixes the problem. You heard a lot about patient-centered care. That's really the key to all of what we do. In the absence of really shared decision-making, patients aren't going to really do what we want them to. And the patient every day makes a decision whether or not to take that pill or give that shot. And if they don't believe us, they're not going to do it. It's got to be a real partnership. So first of all, I've talked earlier and continue to stress the need to customize, to really individualize targets. I have some patients, and I told you I write at the top of the chart every time I see a patient what I think the target should be, again, along with them. Sometimes I write the patient target versus my target, but I have some patients where my target is any, which means I hope the patient survives until the next visit, right? I've got some really brittle patients. They're elderly. I have one woman, she's about 89 years old. She had a pancreatectomy for pancreatic cancer 25 years ago and is still alive. Has her Whipple. She's about, 87 pounds, and she's got Alzheimer's. And if I can possibly keep her alive because she's giving a multiple daily insulin regimen until the next visit, I'm happy. So her A1C is 10 or 11. That's okay with me. And frankly, I don't want to be dinged for the fact that that patient has that high in A1C. Realistically, that's the best I can get without causing harm. So don't be afraid to say this is a patient whose target is X, higher than the target perhaps that's promulgated here. Look at your patients and work with them to do what's safe, because fundamentally that's what we're about, is reaching the target that's the safest for our patients. If the world were magic, we'd want everyone to have an A1C of 6, right? You don't want anyone to have a high A1C. But realistically, we really have to balance it based on our patients and the side effects of medications. So I'm going to give you a series of cases interspersed with some more information about the drugs. But this is a case, a patient, I always say I love each patient, and it's true because they're all such characters to me, and I've followed many of these people for a very long time. This is an 87-year-old female who's an incredibly poor historian, but had a very long history of diabetes when she came in to see me. When I first saw her, it was about 2, maybe now 3 years ago, and her A1C was 12, and she was symptomatic, had polyuria, polydipsia, and nocturia. She was blind in her left eye and had severe retinopathy in her right eye. Her ophthalmologist said she had to control her blood sugars. She had to get her A1C down, so she wants tight control. And in fact, she knows she wants her A1C less than 7. Her A1C is 12, she's 87, and there's a number of caveats. First of all, really every organ system has been touched by some form of illness. She'd had colon cancer and urethral cancer. She was getting steroid injections into her knees. She couldn't walk. She had congestive heart failure, renal insufficiency, really everything. This is not someone where urine my target would be less than 7 unless you could do it magically without causing hypoglycemia, regardless of her eye. Her eye is important, but you've got to put it in the context of the patient. The only medications she was taking were Levoxyl and Losartan. She said she was allergic to TZDs, metformin, and Januvia. She also said she was not going to monitor her blood sugars, and she was not going to learn. She said she would never give an injection under any circumstances, and she could barely ever get to clinic because she couldn't walk, and it was hard to get transportation. And again, she wants an A1C of less than 7. She was a very interesting character. She was French, and she grew up in Algeria, and she's of Sephardic Jewish descent. She has a long family history of type 2 diabetes, and she weighed 10 pounds at birth, probably due to her mother's untreated gestational diabetes. So her target, as I said, was less than 7, and she really was tough. I was thinking of things like giving her a once-a-week injection of a GLP-1 receptor analog, but that would require that I have a visiting nurse go to her house to give it to her because she couldn't get to us. But she was unwilling to take an injection even if somebody else gave her the injection. This was just not something she was willing to do. Somebody asked earlier about when do I measure an A1C. Well, this lady's had diabetes for so long, I figured maybe she had no A1C, no insulin production at all. I needed to know what I was dealing with. So I measured her C-peptide level, and even with an A1C that was high in all these years of diabetes, she was still making a ton of insulin. So you know you've got something to work with. You know you're not mandated to somehow find a way to put her on insulin. Her creatinine is 1.6 and her eGFR is 39, so it limits you in terms of things like metformin and other drugs. She had chronic lower extremity edema and a non-healing left foot abscess. So I go back to the basics of life. I say, well, she's never been on a sulfonylurea agent, or at least she doesn't remember being on a sulfonylurea agent. I'll give her a little bit of glimepiride, a tiny baby dose. I don't want her to get hypoglycemic, but maybe that will help. And this, oddly, is one of those patients, not quite the mayor was talking about, with very high blood sugar levels, where they really respond to a little bit of a sulfonylurea agent. So I up-titrate her to 2 milligrams, and 3 months later, her A1C has come down to 8.1%. All she needed was a drug that she believed in, right? It was going to help her. Things get better. Her A1C comes down now to 7.4%. She's eating better. She's no longer getting steroid injections, which obviously weren't helping. I sent her to a different podiatrist. Her foot abscess is healing. I am so thrilled that this is working, except she calls me. She says she has the measles. Her body is covered in a drug rash to the glimepiride because she was, in fact, allergic to sulfonylurea agents. So I was incredibly bummed by this because I had fixed this whole problem so simply. So I thought about this for a while, and I thought that I would just have to use another insulin secretagogue that was dissimilar chemically, so I put her on repaglinide before breakfast and before dizzy. For reasons unclear to me, through that one remaining eye with its retinopathy, she still read every package insert and got nearly every side effect she could read. It was beyond me. She said, "I feel dizzy. I read in the package insert." I said, "You do not feel dizzy from the repaglinide. You're fine." So she stayed on the repaglinide. She learned to tolerate it. And I think this is what Dr. Fisher was talking about, trust. I really do, because I didn't till the second think of it. But this is somebody who I think didn't take medicines for so long because she just didn't trust them. And she didn't trust it was helping her. She's now 89. I think she just turned 90. She's got an A1C of 7.2. She's actually doing oddly much better. Her eye stabilized, and she's still functioning. So I kind of feel this was a big success. She got better than I ever dreamed she could, but this was really about her and I working together as a team to get her to take a little bit of a medication, which is really all she needed to get her A1C down to something that was reasonable. Now, I'm going to talk about GLP-1 because this is a hormone that's so important and something that's around to stay in terms of our treatment of diabetes. We talked about the fact that there's DPP-4 inhibitors. There's 4: sitagliptin, saxagliptin, linagliptin, and allogliptin, okay? Now, just remember, linagliptin is the only one you don't adjust for renal insufficiency. The other ones have to be dose adjusted. But in all of them, you can use them all the way down to patients on dialysis. So one of the reasons I like these drugs is that in a patient who has basically 0 creatinine clearance, you can still use these agents and they don't cause hypoglycemia. I don't use a lot of DPP-4 inhibitors because I think we have other better drugs, but the reason that they're useful is that they do cause some A1C reduction. They are weight neutral. They don't cause hypoglycemia. They have few side effects, and they're a once-a-day pill, which patients like. GLP-1 receptor agonists come as exenatide, liraglutide, albaglutide, and dulaglutide. Of those, exenatide's either twice a day or once a week. Liraglutide is once a day. Albaglutide is once a week, and dulaglutide is once a week. So I actually believe, and people ask me, what do I tell a patient or a provider to offer in a setting where there's choice, is I say I have patients who are once-a-day patients because some patients just do something by habit every day and it's really good. Other patients are once-a-week patients. I like to give something once a week and forget about it until a week later. Personally, I take Synthroid, and I have to take it every day, and I actually remember because I take it at the same time every day. I'm also supposed to take vitamin D once a week, and I never remember. So I made my vitamin D every day, and I take it. So it's just that you have to know your patients, and they have to know what their preference is. So I just say, if it's a once-a-week person, here's a once-a-week drug. If it's a once-a-day, here. And some people even like the twice-a-day exenatide because it reminds them before they eat that they have diabetes. So this is a place where we have a lot of options for patients. GLP-1 receptor agonists are very good drugs. They cause a very robust reduction in A1C. I just published, or am publishing, a paper where we took from the study cohorts from looking at liraglutide and once-weekly Byetta or exenatide, and we looked at A1C reductions in patients who started out with an A1C of around 10%, and you got about a 2.5% reduction in A1C. So with high A1Cs with these drugs, you'll get a really good fall. And that happened pretty quickly, and it actually was faster than starting basal insulin. You get weight loss, no hypoglycemia, but they're injectable, and they do have GI side effects. So now I'm going to show you a couple of cases using these drugs. This is a patient, and this is the classic kind of patient where I'm going to use a DPP-4 inhibitor. He's an older gentleman. He's got type 2 diabetes and end-stage renal disease on dialysis. When he came to see me, he was on 70/30 insulin twice a day. And this is sort of a frail elderly guy on dialysis. And he eats sometimes, he doesn't eat other times, but he does what you tell him to when he takes that 70/30 insulin, and he's getting hypoglycemic often. And his wife is hysterical. She hates that she's driving him to dialysis. She hates everything, and she hates that he's getting hypoglycemic. So I try to get him basically off that 70-30 insulin onto something that makes him at least more stable. I tried to put him on a more complicated regimen, thinking that his wife could handle this, but she couldn't. So I put him on Lantus with pre-meal dosing, and I said, don't give the insulin if he's not eating. You know, all this flexibility was just too much. They couldn't handle it. So I basically backed off from that, and the real goals that we had, he, I, and his wife, were that they wanted less hypoglycemia, a lower complexity regimen, and also to improve his quality of life, because his life was being quite impacted by having end-stage renal disease. So I added sitagliptin, 25 milligrams, so that's the dose you give when there's renal failure. I first just reduced and then was able to eliminate his mealtime insulin, and I continued him on his basal insulin. I also reduced his self-monitoring of blood glucose levels to once a day, because the poking his finger 4 times a day for the pre-meal insulin was a level, again, of complexity that was unnecessary. So they were incredibly happy to be on a once-daily basal insulin plus a DPP-4 inhibitor, because it made life easier. He wasn't getting hypoglycemic, he could eat or not eat, and he did well. Now notice I'm not showing you A1Cs here, they're not relevant. First of all, he's on dialysis, which alters them, and second, at this point in this guy's life, it really wasn't key. Now, he actually did have pretty darn good glycemic control on this, but here, this was really about quality of life. He then died about a year later of cardiovascular disease, but I felt that I was able to help him have a better management, better life by doing this kind of management. The third case is a case that I've shown for many years, because this was one of the very, very first patients I put on exenatide. And he's a character. He's a 55-year-old guy who had poorly controlled type 2 diabetes. He used to offer to come to talks, like at AAD or something, because he wanted to show off how well he'd done on exenatide. He loved this drug. And really, it's because he sort of gave him his life back. So he was a guy who had been very physically active. He was in law enforcement, but he hurt his back. And so he got new position in light duty, which meant he sat at a desk in front of a computer all day long. He wasn't moving around much. And so he gains weight. He has a past medical history for hypertension, the back pain, no known cardiovascular disease, and he was on metformin 500 milligrams twice a day at his first visit. He weighed 302 pounds, so this had been a lot of sitting and eating. He was 6'1", his BMI was close to 40. On exam, the most striking feature, his pulse was 100 and his blood pressure was 142 over 100. He wasn't on any treatment for hypertension or his dyslipidemia. He needed a lot of help. His A1C was 9.2. Wonderfully and amazingly, his creatinine was 1. His total cholesterol was 302. His triglycerides, 846. His LDL wasn't calculated, and his HDL was 42. So the first thing that was done was his metformin was increased to the maximal dose, a gram twice a day, and we added a sulfonylurea agent, thinking maybe he would respond. His blood pressure was treated with an ACE inhibitor and a beta blocker. He was put on a statin, and exercise was encouraged. He did do better. His A1C came down to 8.1, but he's in his mid-50s. Your target here really truly would be less than 7. So he was started on exenatide, 5 micrograms twice a day before breakfast and dinner, and up titrated to 10 after a month. He had some mild nausea when he started, but that went away fairly quickly, and he tolerated this well. His glyburide dose was reduced by 50% when he was started on the exenatide, which you need to remember to do to avoid hypoglycemia. And he began to feel less hungry. So he starts to lose weight. At his 3-month follow-up visit, his weight has fallen down to 292 pounds, which is close to a 10-pound weight loss. Now, mind you, this guy is not getting to be thin, but for him, losing any weight felt like a miracle. It was very motivating, and it made him very proud of himself. And he also decreased his A1C down to 6.4%, which I think is pretty good, and where you want to keep him. His blood pressure is now 120/80. His heart rate 72. His total cholesterol, he's now on a statin, is 108. With controlling his diabetes, his triglycerides come down to 130, and his LDL is now 54. So this is a guy where he's really beautifully risk modified. You've gone from somebody way out of control and you've gotten him better. But I think the real question, to me at least, is what happens now? What happens a year, 2, 4 years later? Is this guy still controlled? Because you really want that to happen. And actually, I had written up this case early on as a discussion point, a teaching point, and then somebody asked me back for a talk, and they said, can you tell us what happened now? And so I had to go find his chart, because my nurse practitioner is the one who does most of his management, to see what had actually happened to him, and I was a little nervous, hoping it worked. So 3 years later, this is where he is. He's still on the exenatide, 10 micrograms twice daily, plus the metformin. He's been completely weaned off the sulfonylurea agent. I'm not sure how much it helped anyway, but it certainly could cause hypoglycemia and weight gain. He's maintained his weight loss. Again, he didn't lose much below where he was, but he's more active. His A1Cs have ranged from 6.2 to 6.5%, and he does feel better. He feels like he can move around more, do the things he wants, and I'm really pleased with his A1C. Now, you could argue that you might want to encourage bariatric surgery, a whole host of other things, but right now, this guy, this is where he is. He's at his goal, and I think he's doing really well from what I can do pharmacologically to manage him. Now, SGLT2 inhibitors. This is the class of drugs I most didn't want to like, okay? These drugs make you pee out glucose. Who wants to pee out glucose? It is not a good idea. They used to think the way you diagnose diabetes is that people had frequent urination and ants came to their urine, right? That's because ants like sugar. And that's how, in the very beginning, people were diagnosed with diabetes. Just a fun fact, by the way, I have a lot of patients who only want herbal medicine. Does anybody know what herb metformin comes from? Anybody? Theodore? So metformin comes from French lilac, and they actually used it to treat diabetes in medieval times. And it's in the French lilac, or goat's rue. It's a form of guanidine. It used to kill the goats if they ate too much. But when they synthesized it and at least made it sort of not quite as strong, they gave it to people and showed that it helped with their diabetes. So I have patients who won't take pills. They'll only take herbal drugs, and I'll tell them that it comes from French lilac, and they actually like that idea a lot. And then, of course, aspirin comes from willow bark, and some of the statins come from a sort of fungal derivative. You can kind of go with this, you know, in terms of the herbal things, but just say French lilac because it's true. Anyway, SGLT2 inhibitors do not come from anything in nature, but what they do is they make you pee out glucose, and they work. I'm telling you, I didn't think this would work. I thought it was stupid, but I put patients on these. Their blood sugars get better, they lose weight, and it's a pill. It's just unbelievable. Now, I off-label use this in both type 1s and type 2s. It's actually one of the most effective treatments I've had for type 1 diabetes in a long time, because it reduces your insulin requirement, people lose a bit of weight, and their blood sugars actually get more stable. So this drug has really changed how I treat diabetes, and it's been fascinating. Now, there are side effects. Nothing's a free lunch, but these drugs do work. And what they do is they inhibit the basic retransport of glucose out of your renal tubules back into your circulation. So now you're dumping glucose. It doesn't affect your glomerulus. It doesn't affect renal function. Patients always worry about this. But basically what it's doing is it's just inhibiting reabsorption of glucose. It's shifting the renal threshold so people become glycosuric. And I've actually I sit in my exam room and I have, the pieces of paper that patients are supposed to sit on, but I always sit patients at the same level I am because I want to be eye to eye in our conversation, and I draw on the exam table paper. And actually, I have patients who understand these things like renal thresholds, and they say, does it shift my renal threshold? And I draw this little graph, because a normal renal threshold for glucose is 180, let's just say, in healthy individuals. As you get older, that changes, or if you're pregnant. But at 180, most of us would become glycouric. When you have type 2 diabetes, that renal threshold shifts, so you actually have to be more hyperglycemic to urinate out glucose, which is a bad adaptation, right? You're absorbing more glucose than perhaps you ought to. And you give an SGLT2 inhibitor, and you shift that down. So now, when your blood sugar levels are at a lower level, you're going to pee out glucose. So when patients first start taking these drugs, especially if their sugars are high, they become very glycouric. But it sort of stabilizes out as their blood sugars go down. But a patient who takes one of these and then they go out for, say, pasta, will suddenly become very glycouric again, because as long as their sugars go above whatever their new renal threshold is, they're going to pee out glucose. So this is something my patients have actually noted. Some patients say it's sort of like Orlistat, where you used to, if you ate a fatty meal, you had more in terms of side effects. This can be very similar. Almost everybody urinates more when they take these, if you really ask them to honestly look at it. Some patients urinate so much more they can't take these. But it is a diuretic. It's a diuretic for glucose. I also have patients who, say, fly a lot, businessmen who are very busy and racing around, and they don't take their pill on the morning when they're going to go on a long plane flight, right? When you start using a drug, you start learning some of the nuances about it. So remember, this drug pee out glucose, but you can kind of play with it a bit in patients if they're inconvenienced some of the time but like it much of the time. Now, the warnings and precautions to these agents, they can cause hypoglycemia if you mix them with a secretagogue or insulin. They can cause genital mycotic infections, which are much more common in women, and you want to make sure that women are just prepared. I sometimes, if a woman's had a prior history of having a genital mycotic infection, I'll give them a diflucan prescription just to have on hand. Men get it much less commonly, but men are very concerned about this, in part because they've never even thought about having a genital mycotic infection. If somebody is circumcised, they almost never have a problem with this, but uncircumcised men are much more likely to have a problem. And then you have to talk about really having good hygiene. And I also have them get a tube of the over-the-counter cream for women if they get mycotic infections, the antifungal cream, so they can just apply it if they get any redness or irritation. And by having people prepared for this, I've actually not really had any problems in terms of my patients dealing with it. There's a couple of patients, a woman or two who's just gotten genital mycotic infection after mycotic infection that I've just said you can't take this. But in general, people tolerate it, again, if they're prepared. Volume depletion and orthostatic change can happen particularly on patients who are already on diuretics. So I look at the blood pressure. I'll stop a loop diuretic if someone's on a loop diuretic. I generally reduce the thiazide by 50%. And in almost everybody who's being treated for hypertension, over time I actually am able to reduce the antihypertensives. So again, I tell patients, well, I'm stopping your hydrochlorothiazide, I'm giving you this instead. And it pretty much swaps out pretty evenly in terms of volume. But the elderly patient, the patient with a lower blood pressure to begin with, in the summertime, I had some people who really felt dizzy, who really got orthostatic, and I really pushed fluids and make sure that they don't have trouble with this. Just like with the polyuria, they'll get adapted to this, but the first month can be a little bit problematic. They increase the LDL slightly, and I actually advocate following this up at the 3-month visit to make sure you don't need to change their lipid-lowering medicine. And dapagliflozin had 4 cases of bladder cancer in their clinical trials data set versus 0 in the placebo group. So there's in the label a concern about bladder cancer, so don't use it in patients who've had a history of bladder cancer in the past. I don't think this is going to stand up to being something significant, but because it's in the label and because all of our patients hear from lawyers, I just want to make sure that you know what's in the label. So this is a patient, and it's odd because I realized that almost all my patients but the first one were males, but these are actually real patients, so what can I tell you? This is a 4-year-old male who'd had a 10-year history of poorly controlled diabetes, He tried really everything. He tried metformin, sulfonylurea agents, pioglitazone, exenatide, liraglutide, basal and prandial insulins, really everything that is possible for treating type 2 diabetes. Occasionally he got his A1C down, but in general, his A1C was between 8.5 and 10%. Now, this is the kind of patient where I really do ask why. Do you understand the need to get your A1C down? Why aren't you getting your A1C down? And it's never something clear and simple. It's always some vague, I understand, I know, but I can't, I'm busy, I'm this, I'm that. And I actually don't like the word denial ever, but whatever it was in this guy, no matter what I did, it didn't seem to matter. So his BMI is 29. He has no complications. At the last time I saw him, his A1C was 9.7. He was rarely doing self-monitoring of blood glucose, and he was supposedly taking metformin, glimepiride, and basal insulin. So I added in canagliflozin, because it's a pill, and I thought maybe he'd take it. He wanted to lose weight, and I reduced his insulin by 50%, which I thought was slightly humorous, because I didn't actually believe he was taking his insulin much at all. But I did at the college try. I said, take half your insulin just in case you are. And this is what he says to me. This morning I awoke early, 4:45 a.m., and tested and was feeling rested and raring to go. I was 71. I don't think this guy's been 71 in 20 years. At 6:30 a.m., without taking medication nor eating anything, I retested and I was a 96, which seemed normal based on my understanding of how blood glucose levels work at that time of day. I took my Invokana, metformin, and glyburide at 7 a.m. and ate breakfast. An hour after a well-balanced breakfast, and I was at 117. Now let me tell you that this guy got better, not just because I gave him a pill. This guy got better because he got engaged. For whatever it's worth, giving him this pill got this guy engaged in his medical care, because now he's checking his blood sugar. He's saying, look, and I think it's partly because he's now feeling successful. Because when you add in an SGLT2 inhibitor, within 24 hours, the blood sugars come down. It's like that, because you're peeing out all that glucose and you're hyperglycemic. And I think now he's taking his metformin and his glimepiride. So all I can tell you is that he then sends me a series of emails further where he's, again, testing his blood sugars. He's getting better. He says this thing to me at the end of the first paragraph. He says, last night, prior to dinner, I was 136, so I took 20 cc's, meaning units of Lantus. I don't know where that came from. I'm telling you, this guy just does anything he feels like, whenever he feels like it. It's at least here he's being honest to me. But he says, taking the Invokana, I've had one of those really good mornings where I don't have the dullness following the first meal of the day. So what did I say earlier? Cereal. Hyperglycemia after breakfast. You feel exhausted. Suddenly this guy is normal glycemic after breakfast and he has energy. So again, this guy is now finding benefit. And I'm not telling you this is all because I gave him this pill. I'm telling you it's because somewhere in here I gave him something that he seemed to respond to that he's now feeling better about. So that's one case. And I actually just saw that guy. His A1C came down to 7.2. And just to be fair, I saw him again 3 months later, and his A1C is back to 7.9. Why? Why? Because he went back to his old habits. He got really busy. It turns out that what he does is he works on political campaigns. And what did we just have? Political campaigns. So he was racing around and he was stressed, and I don't know who his candidates were, but all I know is he changed his habits. And I came and I said, I can't believe you got worse. And he said, yeah, well, I stopped eating well, and I sort of stopped taking my medicine all the time. And so we're going backward, but at least I have in writing his response to what happened when he was feeling better about himself and his diabetes. Now, this is another guy, and he's 69. He's had a 15-year history of type 2 diabetes. He has had cardiovascular disease. He's got hypertension, low back pain, and psoriasis. And he was referred to me to start on an insulin pump. Now, I don't put a lot of type 2s on insulin pumps because they generally don't need it. But when you get referred a patient, you try to figure out what to do. And this guy was on a ton of insulin. He was taking 100 units twice a day of long-acting glargine. He was taking pre-meal insulin at a dose of 50 to 75 units of rapid-acting insulin before each meal. He wanted to lose weight, so he was taking pramlintide by injection before each meal, and he was on metformin and sitagliptin. So in addition to being on several hundred units of insulin a day, he was taking 1, 2, 6, he was taking up to 9 shots of insulin a day. And his psoriasis was so bad that he literally had just one area on his abdomen that he'd give these injections, and that was getting all lipohypertrophied and nasty. And so the reason his primary care provider had referred him was thinking that if I just put a cannula of a pump in that little area, it would save him all these injections, which is true. But he wasn't a guy who seemed to really want an insulin pump. He was 5'10", he weighed 276 pounds, and his A1C, to my way of thinking, was fine. But again, this was because of this burden, the complexity of his regimen. And so I really wanted to try to reduce this. So he's a guy where what I wanted to do was to give him as few shots as humanly possible. So I added in a once-a-week GLP-1 receptor agonist, because here fewer shots was preferred. I DC'd the sitagliptin, the DPP-4 inhibitor, and the pramlintide, and I cut his doses by 20%. After 3 months, I was able to decrease his long-acting insulin dose from 200 units per day to 60 units per day, and I was able to reduce his mealtime insulin down to 10 to 15 units per meal, and sometimes he didn't need any pre-meal insulin for lunch. His weight fell by 24 pounds, and he had no side effects or severe hypoglycemia. I added in an SGLT2 inhibitor, a pill, and his diuretic dose was reduced. I also, at that point, was able to stop his pre-meal insulin. So now he's on 1 shot a day and 1 shot a week. So it's 8 shots a week as opposed to 8 shots a day. On this regimen, he stabilized out on once weekly GLP-1 receptor agonist, an oral SGLT2 inhibitor, metformin, and 1 shot of basal insulin with an A1C of 7, which isn't that much different, except again, this was really about reducing complexity and changing his regimen to something that was more tolerable. So this is my final case, and I think it fits again with what you heard this morning. This was a patient, still is a patient of mine, who had a 2-year history of type 2 diabetes when he first came to see me. He was on a sulfonylurea agent and metformin, and his A1C was 10.4%. He had no complications and was otherwise doing well. Another guy, articulate, bright, could talk about health care, could talk about what his goals were. But the reason he couldn't reach his goals was clear. 1 year prior to seeing me, his only child, a 21-year-old son, was killed by a drunk driver. So he basically just couldn't take care of himself. He was too sad. Now, he said to me when he came to see me, a year has passed and now I'm ready to take care of my health. But I knew a year wasn't long enough, and I think he did too, because he was still not doing all that well. So what happened is that for 10 years, I followed him. And for 10 years, he drives up from Orange County to see me in my office on the west side, and I added every known drug. And exactly like that other guy, nothing changes, nothing happens, because he's really either not doing it or saying yes and not filling the prescription. Occasionally he gets a little bit better, but not in any way that's consistent. He's always around 10%. And every time I see him, I give him a pep talk, right? And I try to listen and do all those things that are right and do whatever I can. And I always try to give him whatever the newest medication is. I don't know, whatever I can do, right? That's my job, sort of therapist, right? And he never does his SMBG. Sometimes he doesn't come in. Sometimes he exercises. Sometimes he doesn't. His BMI ranges from 33 to 39, so he can lose weight, but he just doesn't maintain that weight loss. So we keep trying. After 11 years, he came to clinic, and I looked at his chart, and I thought I had the wrong chart. His A1C was 6.6, and his BMI was 27. I'm like, what in the heck happened to you? I really thought I had the wrong chart. And what had happened was that without my realizing it, not only had I been giving him medications, he'd actually started taking the medications. And he basically chose the medications he wanted to take. And what he decided was that he was going to take these 3, metformin, canagliflozin, and liraglutide, because they were all, something bad has happened. They were all medications that weren't associated with weight gain, and two of them, canagliflozin and liraglutide, had weight loss. And he also had decided to really work on lifestyle. And because these medications weren't causing weight gain, he was able to really work on his lifestyle, had really consciously made a change in his diet, and was doing a whole lot better. And he's somebody who actually now, a year later, is still doing a whole lot better. And do you think if I hit escape that will go away? No. He's still continue working. Okay. But how do I go to that? Wait a second. I hate these kind of computers. All right. So he's somebody who was able to really incorporate finally what I was saying into his life, in part because I really believe these newer medications allow me to be more successful. If I don't cause weight gain and hypoglycemia, it's easier to adhere. It helped him with his goals, but he just had to get there. And it took him 11 years, but he really did get there, and I was very proud of him. So we choose all sorts of different medicines, and I think we all have to be mindful of what we're asking a patient to do and also to talk with them. We've talked a lot about this. I think everybody wants the miracle drug. If there was a miracle drug, we'd all be rich because we'd all be using it. I'm not withholding anything from any patient. And I think that there's actually a lot of disservice done to our patients by people who promulgate the fact that there's an ability to just have a magic pill. It's never just a pill. It's always an interaction. It's always lifestyle. And our medicines help, but it's really the patient and how they deal with what we give them that helps them in the end. So thank you, and I'll take questions. Thank you. Yes?
Or do you just wait for the next A1C, or is there a way that...
Oh, so SGLT2 inhibitor, if you're monitoring your finger sticks, within 36 hours, your blood sugars are better. So if you just, you can just measure the fasting. The fasting comes down and the postprandials come down. Anytime you're above whatever that new renal threshold is, you just pee out glucose. So your blood sugar, it's amazing how fast you respond, especially the type 1s on insulin. They come down a lot really quickly. So... No, I start, so the pills say if you're going to use canagliflozin, the starting dose is 100 and then you up titrate to 300. I'm really conservative in life, so I take the 100 and I have them break it in half, and I just start on 50 because that way it minimizes side effects. They don't urinate quite as much and they're more likely to tolerate it. So my personal belief is I start low and go up because this is a chronic disease and I'm going to get them better slowly, but if they don't take the pill, because they're getting side effects, it's not going to work.
Do you titrate just based on tolerance, or like you start at 50, check an A1C, see if that...
No, I just do it based on tolerance. If they tolerate... Not necessarily. Sometimes they get better enough at 100, but I see, sometimes I'll go to 150, which is half of a 300. I mean, anything it takes to get somebody to where I want them. I don't have an algorithm in my brain that they have to go to 300. It's whatever the most effective dose for that person is. I do a ton of follow-up on email or people text me. So I do a lot of the fasting, trying to get it to where I want it. Yes? So if I was starting an SGLT2 inhibitor in a type 1, I reduce their basal by 10%, and I generally reduce their prandial by 25%. It works very quickly, and then I'll often have them give the prandial insulin after they eat at first because they may find their sugars have gone so far down that they're not going to need much at all. So I'm really careful at first in a type 1. Oh, wait, she was next and then you.
One more question because we're going to wrap up.
I was just going to say the obvious elephant in the room is that we can't prescribe on these formulary. So have you heard, I mean, we know that there's been some rumor that potentially SGLT2 inhibitors might cover this agent with them. Do you guys see that?
Well, I'm pushing for it, shall we say, because they work. They're an oral agent, and if we can, people on insulin have the hardest time, and I think they have the hardest time getting to target. And so I think if we can circumvent everyone having to go to insulin with this kind of agent, it will actually save money. So we're working on it.
Yes.